Hi everyone, this is Tim, your Block 3 lecture instructor, and this PowerPoint voiceover is on the renal system, primarily UTIs, cystitis, glomerulonephritis, and pyelonephritis. So the kidney is actually meant for urinary elimination. It also maintains fluid volume and composition, and it also filters waste products for elimination. So keep it simple. Basically, your patient consumes fluids, and whatever is not needed is actually excreted. This also goes for potassium, sodium, magnesium, phosphorus, all your electrolytes that are needed. Your body will actually hold on to, and the kidney is what actually does that. And again, if it doesn't need it, the kidney also will kick in and say, hey, we don't need as much, and it'll start to eliminate that stuff. And it gets eliminated through the actual waste, which is urine. The kidney also regulates blood pressure. So again, if your patient has low blood pressure due to, let's say, dehydration, the kidney actually knows to say, hey, you know what, stop producing urine and let's hold on to as much fluid as possible. The acid-base balance is the same. It also produces erythropoietin, which is a red blood cell synthesis. So if you have a patient who is low on red blood cells, the kidney will actually kick in and say, hey, we really need to produce more. It sends this signal, which is erythropoietin, and says, hey, let's produce more, and then your body starts to do that. It also converts vitamin D into an active form. So if you have patients, especially elderly patients, who should be consuming more calcium and vitamin D for bone strength, the kidney is actually turning the vitamin D into something to be able to bind and allow that calcium to work, so your patients do get stronger. So here's a picture of the renal system. We got basic anatomy. It's a kidney, urinary tract, ureters, bladder, and urethra. So kidneys actually produce the urine. It goes from there into the ureters, travels through the ureters to the bladder itself. And then once it hits the bladder, you've got to go and then you eliminate it. Now, as far as regulatory function, here's a picture of the glomerular filtration and the tubules. Don't spend too much time memorizing all this stuff. I really just want you to be more aware of what the kidney does and how that really happens. So again, it maintains the fluid balance. So if your patient is dehydrated, it will hold on to it. The tubulars actually are the ones that actually kind of filter it and reabsorb it. And again, if your patient drinks way too much water and doesn't need it, then the tubulars will do the same thing. And again, this goes from either fluid itself or the electrolyte. So keep all that in mind, that whatever you don't need, it really just gets rid of, and the kidney, if they work correctly, will actually know how to do that. Now, as glomerular filtration, this is where the urine is formed. Again, it's based on water, electrolytes, creatinine, the nitrogen, and glucose. If your patient's kidneys are working correctly, they really should be excreting 1 to 3 liters of urine each day. What the kidney does not do is not actually filter blood cells, albumin, or proteins, and that's because of the fact that these are too big and they're usually filtered by something else. Now, as far as tubular reabsorption, again, it reabsorbs most filtrates. Again, it's the water and the electrolytes. Keeps normal urine output balanced. So, a normal person who's drinking plenty of water every day should produce 1 to 3 liters. And again, this is, going to be based on how much it needs at the time. You could drink a gallon of water in the morning, but if your body doesn't need it, you're going to urinate that out. But if you drink water slowly and throughout the day, and let's say you go outside and it's 110 degrees outside, you start sweating, even though you've consumed that much fluid to stay hydrated, you've lost that fluid somewhere else. So the kidney actually knows to, hey, let's hold on to that stuff and make sure that you stay hydrated. So here's a slide on the ureters. It connects the kidney to the bladder. It's a 1/2 inch diameter. It's 12 to 18 inches long, and it narrows in 3 areas. The reason why this is important is because if you have patients who produce kidney stones and those stones are working their way out, those narrowing areas in the ureters is where those kidney stones get stuck, and that's usually where the pain is formed. So if you have a patient who is passing stones and they're like, oh my gosh, it's stuck right here and it hurts so bad, that's usually an area where it's narrowed, and again, it's really just stuck there. The best thing they could possibly do is drink more fluid. We can actually hydrate them as much as possible, and that's really just so the kidneys produce more urine to keep trying to push that stone out. So here's a slide on the urinary bladder. It's an internal urethral sphincter. The pudendal nerve, and the reason why I put this in here is because your patients who have Foley's placed, that balloon that is used to anchor that Foley will sit right at that nerve, which is at the base of the bladder. So if you have patients who have a Foley catheter and like, oh my gosh, I have to pee, I have to pee, I have to pee, well, it's because that nerve is being aggravated by that balloon. So the best thing you really can do is just um, keep telling them that it's because of the balloon, and there's not much you really can do about it. But usually this affects more confused patients because they feel like they have to go, and that's what the nerve is meant to do, is to tell you that you have to go. But they just keep forgetting they have that Foley, and that's where the balloon is sitting. So the next one's the urethra. For men, it's 6 to 8 inches long. It usually goes through the from the bladder through the prostate to the actual pelvic floor and to the penis and out. Women, it's 1 to 1.5 inches long. Theirs is actually shorter, so they're more apt to get urinary tract infections because of the fact that it's shorter and it has a shorter distance to travel. Whereas for men, because it's longer, we tend to be able to care for it or take care of it before it gets too much of an actual problem. Now, as far as lab tests, so if you have a patient who comes in that has either kidney issues or some pains or have some urinary problems, they will do a blood test. And this is really just to check if the kidney is functioning correctly. They're going to check their BUN and creatinine. The creatinine is usually 0.5 to 1.2. This will possibly change based on where you work or what doctor is actually measuring. So don't get hung up too much on, oh my gosh, it's 0.4 or it's as high as 1.3. A lot of times it's a range that even one point higher or lower is not that big of a deal. What I do want you to kind of understand is that if they are 0.5 or they are 1.2, that they are really kind of approaching a too low of a number or they're approaching too high of a number. And based on what's going on and what we want to do to fix, we might look at that a little bit more in depth. Um, for the creatinine, it's produced when protein and muscle breaks down. So you may actually have someone who comes in with a very high creatinine, but if they do tend to work out a lot and they tend to be more muscular, the muscle breakdown itself will cause their creatinine to go up because of that breakdown. Um, Based on the fact that we know that that's the cause of it, we probably usually don't do too much because of the fact that we know to expect it to be high. And again, the body will actually the kidney will try to do what it can to fix that problem. Now, if they came in and grandma's 80 years old and her creatinine is really super high and she's not muscular, then we will then look at other issues. Let's see here. So the creatinine is also filtered through the kidneys and excreted through urine. So again, it's basically a waste product. Increases with kidney impairment. So if the kidneys aren't working, that number goes up, and it decreases with decreased muscle mass. So again, if grandma's 80 and she's pretty much has no muscle, she should be fairly low. Other lab tests, they're going to look at BUN, which is 10 to 20. It's a byproduct of protein breakdown in the liver. So if you have either liver problems or if you have a lot of protein that is broken down, or if you have people who consume a lot of protein, your BUN actually might be a little elevated. And again, it's not so much, oh my gosh, your BUN is really super high. It's why is it high? Can we explain it? And can we actually do something and not necessarily be a liver or kidney issue? Let's see here. Urea nitrogen is metabolism of food sources and proteins. So again, if you have patients who are either consuming too much protein, whether it's powder or it's actually eating steaks 3 times a day, that could go high. Now, we also are looking at the kidneys to find out if that's affected, but we're also looking at them and wondering why they're eating 3 steaks a day and whether or not they've got other issues like high cholesterol and cardiovascular problems. Let's see here. The BUN can also be increased based on hepatic or renal disease. Dehydration, that's actually a really good point. Between the BUN and creatinine, if your patient is dehydrated, their BUN and creatinine will actually go up because now you've got more waste in a smaller concentration of fluid. And that can be fixed if you really just hydrate your patient. So again, look at the source, find out what's really going on, and if it's something so simple as hydration, it might actually fix it without looking and going, I think there's some kidney damage when there really isn't. Other urine tests, they'll do a urinalysis. This is collected first thing in the morning at the first void, and that's because of the fact that you've not gone for 8 hours. And whatever's actually there is probably going to be the best source of a urinalysis. You're looking at color, consistency, and smell. Um, eh, you after a while will actually know based on looking at your patient, looking at their urine, and just knowing that it's dark and it's cloudy and it stinks, you'll kind of learn how to diagnose your patient with urinary tract infections because it's abnormal. I mean, if you look at your own urine and you're healthy and it should look like a certain way, and you look at your patient and go, "Ooh, that's gross," most likely something's happening. Other urine tests are going to look at specific gravity. This is density of urine compared with water, which is 0.000. Normal is 1.005 to 1.03. I think some books actually go from 1.005 to 1.002. Again, don't get hung up on the idea that it's just off by, 1/100th of a point. Just kind of know that if it's really high or if it's really low, that there's really something going on with the kidney. Again, this specific gravity can be increased by dehydration. It can also be decreased with increased fluid intake. So we tend to get a lot of patients, especially living in Arizona where it's so hot. We tend to get a lot of patients that are either dehydrated, or we tend to get a lot of snowbirds or a lot of patients from skilled nursing facilities that are pretty dehydrated because they're just not consuming enough. These will throw all your labs off. So again, if we hydrate everybody first and find out, okay, so we fix the hydration problem, but your labs are still high, it might be something else that's going on. So let's see here. So specific gravity, I'm not going to make you memorize a million zillion numbers, but just kind of be aware that the specific gravity for a pH normal is 4.0 to 8.0, and again they're really looking at the acidity and the alkalinity of the urine. So again, if it's too high or too low, it might be a kidney issue, it might be a hydration issue. Once you kind of look deeper and find out if there's also something else going on, then they start to go from there. Um, Glucose will increase with hyperglycemia. Again, that could be either a dehydration issue or maybe they actually have a diabetes problem. Ketones will actually show up. That's fatty acids and diabetic ketoacidosis. If proteins start showing up in your patient's urines, they actually, if they've actually got a major kidney issue because now it's really filtering things that it should never really filter. Um, Again, same thing with red blood cells, white blood cells, and nitrates. Um, if nitrates actually show up in your patient as far as their urinalysis, usually it's an E. coli problem, and that's really just a hygiene problem. Their E. coli comes from the rectum, and because it's in proximity to the urethra, if their patients tend to get a lot of UTIs, especially if they're older and women, it's more like again, it's more of a hygiene issue, and we really need to perform more education than anything else. Diagnostic tests, bladder scan will tend to bladder scan patients after they've voided to find out if they're retaining. They may look at a CT scan, and this will actually measure the kidney size and assess for masses. An ultrasound will also measure the size of the kidney, detect tumors or obstructions. MRI will tell you whether or not there's actually some sort of cancer that's being produced, and they may also do a renal scan, which is a kidney flow and glomerular filtration rate. That's really just to find out, okay, so you are having kidney issues, but let's find out what degree that is and find out if your kidneys are still filtering and actually still producing urine, or are they not, and what degree and what stage of that kidney problem are you? So as far as cystitis and UTIs, it's basically a inflammation of the bladder. Infection is usually caused by bacteria, viruses, fungus, or parasites. It really can, I mean, a UTI is a urinary tract infection, and it could be any four of those things. We just do urinalysis to find out what really is the cause. They'll do a culture and sensitivity to find out, what caused it and what antibiotic is going to be the best one to actually get rid of it. Infection moves from the urethra to the bladder. So essentially, it travels north. So it starts with the urethra, it goes north, and it's going to go from urethra to the bladder, from the bladder to the ureters, and then it actually hits the kidneys. So basically, UTI, like I said, it starts in one area and it has to end in the other. Organisms grow in perineal area and move to the north. So again, it could either be a hygiene issue, and again, it's just a matter of teaching your patients how to clean themselves better. 50% of patients with a catheter become infected within 1 week of catheter insertion. I threw this on here because of the fact that, we do so many Foley catheters. And if you remember from block one, we beat it into your head about sterile technique. And it's because of the fact that, you're putting something inside someone's body. And if it's, contaminated, it's going to cause an infection. And we have caused it because we put it there. So just keep in mind that, again, as much as you thought, oh my gosh, this is so, tedious to put a catheter in, it's really because of the fact that the insertion itself and everything else you've done is easy. It's just making sure that you don't give them some sort of infection. Adding an infection to a patient, especially to give them a UTI, added on top of why they're there, which could be a million different reasons. Now their body's trying to fight two different things instead of just one. So as far as labs, again, they're going to do a urinalysis, they're going to do a culture, they're going to do a sensitivity test to find out, what infection they do have and what antibiotics can be the best one to fix that. They're testing for leukocytes, esterase, and nitrates. They're looking for bacteria, white blood cells, and red blood cells. This determines if the patient has a UTI, and again, what drug is actually going to be the best one to actually fix it. As far as drug-wise, for you guys, for this block, I want you to know ciprofloxacin, which is Cipro, levofloxacin, which is Levaquin, amoxicillin, and Augmentin. And we'll talk more about those in class. So pyelonephritis. So basically, your patient has a UTI and it's gone from the urethra to the bladder, from the bladder up to the kidney itself. It's a bacterial infection in the kidney and the renal pelvis. It could either be chronic, which is from grandma constantly getting UTIs, or it can also be from patients who are young enough that they think that it might be UTI, but not quite sure. They think it might be getting better. They kind of wait it out, and next thing you know, it really has gone from being a simple UTI to a raging UTI. And again, it's going to go as far as north as it possibly can. The furthest it can go is pyelonephritis, and at that point, they've got, again, the worst UTI they could possibly have. This is also going to be from a defect or obstruction. So if you have patients who have kidney stones or something else is going on and urine isn't flowing right, it's not coming out. Just a little bit of infection, and then next thing you know, you've got urine that's sitting somewhere, and it's just allowing that bacteria to actually grow. Let's see here. I think that's it for that. So assessment of the pyelonephritis. So assessment is going to be fever, chills, tachycardia, tachypnea, flank pain and loin pain, abdominal discomfort, nausea, vomiting, and recent treatment for a UTI. So if you have a patient who has had a UTI, was on antibiotics for, let's say, 7 to 10 days, and then within a week after that they come back with another UTI, it's because the antibiotics weren't good enough or just strong enough to get rid of what they had. That simple UTI, again, if the antibiotics were not good enough to fix it, it will literally just travel north until it gets to pyelonephritis, and at that point they just need stronger antibiotics. Again, lab-wise, you're going to be looking at urinalysis, leukocytes, white blood cells, bacteria, red blood cells, and protein. They might also do blood cultures. They're going to be looking at C-reactive proteins and erythrocyte sedimentation rate. Those two labs are actually markers for inflammation and infection. They want to do blood tests to find out if it went from pyelonephritis, which is a simple UTI from the urethra to the bladder to the kidney, but if it's gone from the kidney to the bloodstream itself, now they've got a super infection going on, and that blood culture will tell you whether it's actually reached the bloodstream or not. Diagnostic testing, they'll also do a X-ray, or what they call a KUB. The KUB is an X-ray of the kidneys, ureters, and bladder. So they're now looking at the kidneys, they're looking to see if there's anything stuck in it, they're looking for stones in the ureters, they're looking at the bladder to see if there's something else stuck there too. Treatment-wise, as far as if you have a patient who does come in and actually gets diagnosed with a UTI or cystitis or polynephritis, it is very painful, and they're going to prescribe pain medication and NSAIDs. The NSAIDs are going to be the anti-inflammatory, so that way the pain will be at least decreased, and the pain medication is really just to help them out along the way. For non-surgical treatments, again, they're going to do antibiotics. They're going to, do some nutrition, also do some education. You might do some fluid therapy to help filter and to clean out the system. Now, as far as surgical, I mean, if there really is something either stuck somewhere between kidney to urethra, or if there's some sort of mass and they just find out that it's there, they might actually remove the problem itself. And sometimes, removing the problem is going to fix all of your problems. But usually UTIs, cystitis, and polynephritis is usually taken care of by antibiotics. Now, as far as urosepsis, so again, your patient went from a UTI to a bladder infection to polynephritis. They waited too long or it got too bad and it literally hit the bloodstream itself. So once it's done that, your patient has gone septic, and it's urosepsis because that's where it really came from. As far as physical assessment, they're going to again look at a urinalysis. They're going to look at it and tell whether as far as cloudy, foul smelling, blood tinged. There might be some sediment in it. It looks like this picture. It's pretty nasty and pretty gross. But again, that tells you that it's really gone as far as it possibly can. It's hit the bloodstream, and your kidneys are working way, way too hard trying to filter all that stuff out, and there's not much left. Plus, if your patient has a UTI or polynephritis or urosepsis, they have literally urinated as much as they possibly can because the body is trying to get rid of that infection. We know it's not going to work, but the body doesn't. So based on the more they urinate, the more dehydrated they get, the more their urine gets concentrated. So it gets darker and thicker and stinkier because of the fact that there's not much urine being produced as far as water being left as far as the body. So that's what's left over, is just that concentrated waste. As far as lab-wise, they are again looking at urinalysis, they're looking at cultures and sensitivity to find out, exactly what will actually, what it will actually take to get rid of that infection. And that's pretty much it. So this was down and dirty. I know it was pretty quick. I wanted to make it as simple as possible. I really wanted to just introduce these things so that way you had a better understanding of what we're going to be talking about in class. Definitely read your book, use your other study materials, ask a lot of questions, and we'll kind of go from there. So let me know if you need anything.